Hello, welcome to Midwifery class, a place where you can find thousands of learning aids for your projects. My name is Dr. Joshua. I'm a nurse educator, and in this video, I'm going to be taking you through the Bishop score. What is the Bishop score? The Bishop score was developed by Dr. Edward Bishop and published in 1964. It is also known as the cervix score. It's a pre-labor scoring system that is used to do three main things. 1. Bishop score is used to assess the favorability of the cervix for induction of labor. In many situations, you're wondering whether or not to induce labor because you're not sure of what the outcome of your action would be. In this case, you can use a Bishop score to tell you the likelihood that if you induce, this induction will result into a successful vaginal delivery. The second thing we can use a Bishop score to do is to predict the likelihood of a preterm delivery. One of the key parameters that is used in the assessment for a Bishop score is the cervical length. Many studies have indicated a relationship between cervical length and then the duration of pregnancy, in that the shorter the cervical length, the more likely you are to have a preterm delivery. The third thing we can use a Bishop score for is to confirm the diagnosis of labor. This is possible because all the parameters that are used in a Bishop score are also the parameters used to establish the onset of or monitor the progress of labor. So we can happily and confidently say you can use a Bishop score to confirm the diagnosis of labor. So what are these parameters that are used in the Bishop score? I have listed for you these parameters here. There are 5. The first one is the cervical position. The second one is the cervical consistency. The third one is the cervical length or effacement. The fourth one is cervical dilatation. And the fifth one is the station. All these parameters can be summarized in these mnemonics P-SIDS, where P is for the position, C is for consistency, E is for effacement or cervical length, D for dilatation, and S for the station. All these parameters can be assessed by digital vaginal examination. However, it's a little bit difficult to estimate cervical length using the finger, and even if you did so, you would still be less accurate compared to when it's done using an ultrasound. Let us go ahead and look at these parameters one by one. The first one is the cervical position, which is the location where the cervix can be felt within the vagina. It can be anterior, where the cervix tilts towards your front, or it can be midpoint, where the cervix is midway between anterior and posterior, or it can be posterior, where the cervix tilts toward your back or your bum or the spine. Towards term, the cervix moves from behind your baby's head close to the spine in a posterior position towards the top of the baby's head in an anterior position. An anterior position is favorable for delivery because the head applies pressure directly to the cervix, aiding dilatation and effacement. Let us go ahead and look at the second parameter, which is cervical consistency. This is how you feel the cervix when you touch it with your examining finger. The consistency can be firm, where the cervix feels like the tip of your nose, or it can be medium. In this case, it's moderate. The cervix feels anywhere between firm and soft. Or consistency can be soft, where the cervix feels like the tips of the lips of the oral cavity. I'm assuming you've ever touched your lips and you know how a soft cervix feels exactly. A soft cervix is more favorable for vaginal delivery because it dilates and effaces fast. Let's go ahead and look at cervical length and effacement. Cervical length is the length or the distance between the internal and external cervical hairs. It's best measured by sonography and is expressed in centimeters. Shorter cervical length is associated with shorter gestational age. We have seen this before. The shorter the cervical length, the more favorable the cervix is for a vaginal delivery. After knowing this, let's go ahead and also take a look at the effacement. The effacement is the shortening and thinning of the cervix. Some medics describe it as taking out of the cervix because a fully effaced cervix cannot be felt. That's a point to note. And cervical length is a better indicator compared to effacement. Why? Because when you use effacement to give your bishop score, the inter-observer variability is far greater than when you use a cervical length. Knowing this, let's go ahead and look at the cervical dilatation, which is the fourth parameter we're going to look at. It's basically opening of the cervix. The cervix is the entrance to the uterus. Cervical dilatation is a diameter that is expressed in centimeters. It's 0 centimeters when the cervix is closed and 10 centimeters when the cervix is open to its widest possible diameter, or perhaps what by convention we call the widest possible diameter. An open cervix is an indicator for readiness for or onset of labor. And knowing that, we can go ahead and look at station. Station is the descent of the presenting part into the pelvis. The presenting part is the part of the fetus that lies in the lower pole of the uterus. Station is basically how far the presenting part has moved towards or beyond the ischial spines. Above the ischial spines, station is represented as negative numbers: -5, -4, -3, -2, -1. If the presenting part reaches the levels of the ischial spines, station is described as 0. And when it descends further and moves below the levels of the ischial spines, station becomes positive numbers like +1, +2, +3, +4, and +5. Now, -5 is a very high presenting part that descends through 0 all the way to +5. The lower the presenting part, the more likely is a vaginal delivery. As we can go ahead and look at this simple illustration of station where we have the pelvis there with the head as the presenting part, and in this case we can look at the ischial spines, and the presenting part is at +4. So this station is described as +4, and you use this technique in all the other measurements of when you want to establish station. Now, it's important to note that station is established also on a vaginal examination. Now that we have looked at all the parameters, let's go ahead and look at what we call the Bishop score. In this table, we have the Bishop score. On the left, we have the parameters. Then on the right, we have the score itself. The parameters are the position, consistency, effacement, dilatation, and then the station. Then the scores are given from 0, 1, 2, and 3. The first parameter we're going to look at is the position. Do your assessment and establish the location of the cervix. If it's posterior, give a 0. If it's midpoint, give 1. If it's anterior, give a 2. Then go ahead and assess for consistency. If it's firm, give 0. If it's moderate, give 1. If it's soft, give 2. After consistency, take the effacement also. Take the length. When the cervical length is for more than 4 centimeters, in this case the effacement is anywhere between 0 to 30 centimeters, give a score of 0. If you have taken your measurement and the cervical length is between 3 to 4 centimeters, the effacement is 30 to 50%, give a score of 1. Or if you take your cervical length and it's 1 to 2 centimeters, In this case, the effacement is 60 to 70%. Give a score of 2. And if you take your measurement of cervical length and it's less than 1 centimeter, in which case the effacement is 80, give a score of 3. Then go ahead and take the cervical dilatation. When the cervix is closed, give a score of 0. When the cervix is 1 to 2 centimeters dilated, give a score of 1. If the cervix is 3 to 4 centimeters dilated, give a score of 2. If the cervix is 5 centimeters or 6 or any number above it, give a score of 3. Then move ahead and look at the station. If the presenting part is still very high, that is -5, -4, -3, give a score of 0. If it is at -2, give a score of 1. If the cervix is just above the levels of the ischial spines, that is at -1, or at the levels of the ischial spines, give a score of 2. If it has descended below the levels of the ischial spines, that is +1 or +2, give a score of 3. So after getting all this score, depending on what you have found upon assessment, how do you interpret your results? You will add up all this score, the total score. The minimum score you can get is 0, while the maximum score you can get is 13. Now, after getting the score, if you get a score of more than 7, this means that if you induce, your induction will likely result into a vaginal delivery. Then 2, depending on the individual parameters, your score dictates which method is suitable for induction. For example, if you get a cervix that is still firm, it means you have to use a drug to soften the cervix. Okay. Then what if you get a score that is less than 7? What do you do with a score that is less than 7? It indicates that induction is less likely to result into a vaginal delivery, and in this case, it's recommended that you don't induce unless you're inducing for a very serious medical reason. It will not be a successful induction. Otherwise, thank you so much for being part of the midwifery class. Let's continue to learn, to grow, and to serve together. Journey.